Welcome to the University of Kentucky's Department of Anesthesiology YouTube channel. This is part of our high yield keyword review. It's part 4 of a 5-part series on the topics respiratory anatomy, physiology, and thoracic anesthesia. As a reminder, we're covering keywords published by the American Board of Anesthesia, actually over about the last 12 years, but from the last year, 2019, these are the keywords that are represented in purple throughout the 5-part slide set. Respiratory keywords make up about 10% of all the in-training exam keywords. And we'll start right in on our next one, which is anterior mediastinal mass. An anterior mediastinal mass is represented by the X-ray at the top right, and you can see how that mass could easily compress the trachea and potentially compress vessels returning blood to the heart or part of the heart itself. So if you have an anterior mediastinal mass, you worry about its impact on the airway as well as on cardiac output and blood return to the heart. The anterior mediastinal mass may compress the heart, the SVC, the tracheus, the bronchi, and it may become worse when you take that person and put them in a supine position. Kids, most of these tumors are malignant lymphomas, germ cell tumors, and thymic tumors are examples. When a CT of the chest is done and you look at it, if you see tracheal bronchial compression greater than 50%, that's considered really dangerous, unsafe to anesthetize with general anesthesia. If you happen to do a pulmonary function test flow volume loop, which isn't usually done very much anymore, but if you did, this would be a variable intrathoracic obstruction, meaning that it's variable, there's a difference between inspiration and expiration. Intrathoracic, that's where the pathology is in the chest. And you would see this expiratory plateau. That is, as you inspire, air comes in, but as you expire, that tumor presses on the trachea or the bronchus and impedes expiratory flow. A TT, transthoracic echo, could be done to look at, is there vascular compression, cardiac compression from this anterior mediastinal mass. When you manage an anterior mediastinal mass, again, it's important to look at the CT scan, and if the tracheal bronchial diameter is reduced by less than 50%, you might want to think about, one, doing local anesthesia to try to biopsy a lymph node, for example. That might help you make the diagnosis and start chemotherapy or radiation to shrink it before you go to full-blown surgery. If you use inhalation induction with spontaneous ventilation, that is favorable to positive pressure ventilation because it tends to maintain airway patency. However, this is pretty difficult to do in many of these cases. And if possible, avoiding muscle relaxants and maintaining negative pressure breathing is optimal. Again, very difficult. Sitting lateral prone position may be better than supine position. Supine position is especially and frequently associated with obstruction of the airway, the trachea, the bronchus, etc. If a patient went to sleep and became obstructed, having a rigid bronchoscope in the room is recommended. You could take that rigid bronchoscope and pass it past the obstruction and ventilate, for example, one lung and at least keep the patient alive until you could do something else. Having cardiopulmonary bypass in a standby mode with or without femoral vessel cannulation can be used if the patient is really bad, really dangerous, lots of compression of the airway. You might even establish cardiopulmonary bypass or an ECMO support before going on and inducing general anesthesia. Moving to the next keyword, pulmonary function test before removing a lung, pneumonectomy. In the past, pulmonary hypertension, if they had that, if their CO2 at baseline was greater than 46, and if their predicted postoperative FEV1 was less than 800 mils, that was considered a contraindication to taking out a lung. Now, the only cure for lung cancer really is surgical removal of it, so this basically did not allow them to have a chance at cure. The worry, though, was that if they had one of these, pulmonary hypertension, they could, if you removed a lung and made the blood that went to 2 lungs now only go to 1 lung, the right ventricle is going to have to work harder and it could fail. If the PCO2 was already 46 and you removed 1 whole lung, CO2 is going to go higher. You leave someone as a postoperative respiratory cripple requiring a tracheostomy and ventilatory dependence. Same thing with the FEV1. You just can't get enough air out and you're going to be ventilatory dependent. So a three-legged stool of pre-thoracotomy respiratory assessment has been proposed ways to look at, is this person able to undergo pneumonectomy? You can look at respiratory mechanics, things like FEV1. Is the postoperative FEV1 expected greater than 40% of normal? Cardiopulmonary reserve, what's their VO2 max? Can they climb stairs? Can they do a 6-minute walk? How far can they go in a 6-minute walk? That's estimates of their VO2 max. Can they use oxygen and how well? And then lung parenchymal function, can it exchange oxygen very well? DLCO, or diffusion lung for carbon monoxide test, can be used. And hopefully it's greater than 40%, which puts them in a category oftentimes of more resectable rather than not a candidate for a pneumonectomy. Smoking cessation is the next key word. Stopping smoking before surgery obviously is recommended. Stopping smoking anytime is recommended. But if you stop just for a short term, several days before surgery, there are some benefits. And those benefits include that nicotine level is low. Half-life of nicotine is only about 20 to 30 minutes, so the sympathetic stimulant is gone at the time of surgery. Decreasing the amount of carbon monoxide over just a couple days of stopping smoking, carboxy hemoglobin levels decrease, so your oxygen carrying capacity is going to go up. Carbon monoxide also shifts the oxyhemoglobin curve to the left, which means it's not going to deliver oxygen as well to the patient. If they stop smoking and have less carbon monoxide, it's going to shift back to the right, increasing the P50. Better delivery of oxygen to the tissues. However, just stopping for a couple days doesn't have a great effect on the major postoperative pulmonary complications or on the amount of mucus produced or improvements in pulmonary function tests. Long-term cessation is required for that, and that's more than 2 months or more to decrease postoperative complications related to the lung. And that is stopping the large amount of sputum that they produce, the ciliary coming back and sweeping again, the FEF 2575 mid-expiratory flow rates improving, closing volume improving, and return of normal immune function and hepatic enzyme activity. Hepatic enzyme activity is actually cranked up by cigarette smoke. So short-term versus long-term cessation, different outcomes, but both are desirable, and stopping smoking, whether it's for a couple days before surgery or preferably a long time before surgery, in an attempt to decrease postoperative pulmonary complications. The next key word is one-lung ventilations, the indications for one-lung ventilation. There's some absolute indications like trying to prevent the good lung from getting blood in it or pussy fluid in it, or when you're going to lavage one lung for protein alveolosis, for example, and you don't want that lavage fluid to go into the other lung. Bronchial pleural fistula, where if you are ventilating both lungs, the air that is going to go down the least path of resistance, which is down into the lung with the bronchial pleural fistula and out the fistula, and you may have very ineffective ventilation of the good lung. And so absolute indications are those for one-lung ventilation. Now, we usually use one-lung ventilation for exposure of surgical sites, that is for thoracic surgery, removing part of a lung, thoracic aneurysm surgery, esophageal surgery. That's a relative indication, however. And how you separate the lung can be with a double lumen tube up at the top right, with a bronchial blocker passed down through or on the side of an endotracheal tube and out into the bronchus that you want to obstruct, or even passing an endotracheal tube deep into the bronchus and making it an endobronchial tube, and single lung ventilating through just that deeply placed single lumen tube. Now, if you do endobronchial intubation, whether purposefully or non-purposefully, and the example would be, I just passed a tube after intubation. Instead of down to 21 to 23 depth, it's now down to, let's say, 27 or 28. And it would likely go out the right mainstem, and that would be an endobronchial intubation. Saturation would drop. Hypoxic pulmonary vasoconstriction would kick in because the left lung would not be being oxygenated. Pulmonary arterial pressure would rise. You'd have big VQ mismatch because you would have blood going to the left lung, not being ventilated. That's shunt. And initially you would see an end tidal of CO2 that would drop because you're delivering a full minute ventilation to only one lung. And if you were delivering a volatile anesthetic, there would be a decreased uptake of that volatile anesthetic, and you would expect some of your airway pressures to be high. So those are things associated with endobronchial intubation. Let's move on now to bronchial blocker, a method of isolating a lung. There's some advantages represented in green, disadvantages in red, and the complications in purple represent an IT keyword from 2019. Up at the top right is a bronchial blocker coming down an endotracheal tube, and in this case, blocking off the left mainstem bronchus. Some advantages of using a bronchial blocker: it's easy to recognize anatomy. If the single lumen tube is in mid-trachea, you can recognize, okay, that's the left mainstem, that's the right mainstem. I suspect some of you who have placed a double lumen tube may have placed it occasionally too deep in the right, and sometimes you can get confused. Which is the carina? Is that the takeoff at the right middle? Am I just too deep? So easier recognition of anatomy if the single lumen tube is mid-tracheal. It's the best device if it's a difficult airway. It's harder to put a double lumen tube down than a single lumen tube, and if you can get a single lumen tube down, that person that's been difficult to intubate, then you can put a bronchial blocker through it. Cuff damage sometimes occurs when you put a double lumen tube down because of the two cuffs, and sometimes brush against the teeth, and you get it in place, and then you realize, oops, one of the cuffs was broken and it's not going to work. At the end of a procedure like a lung surgery or a big thoracic aortic surgery, and let's say if the patient was somewhat difficult to intubate, it's so nice to not have to replace the tube. You can just pull the bronchial blocker out, leave the single lumen tube, continue mechanical ventilation. If I have a double lumen tube in a patient at the end of a long procedure where they may have airway swelling or it was a difficult intubation, I may choose to actually drop the bronchial balloon and leave the double lumen tube in for up to 24 hours or so to let the swelling go down before either changing it out or extubating someone from that double lumen tube. So no need to replace a tube if you've used a bronchial blocker at the end of the procedure if you're going to continue them on mechanical ventilation. Also, you're able to isolate at a lobar level rather than just at the mainstem level. For example, if you want to put that bronchial blocker all the way out the right mainstem down the right middle lobe, you could just selectively isolate the middle lobe of the lung, and as someone with really bad lungs who you're working on the right middle lobe, you could potentially have better oxygenation rather than blocking off the whole right lung, just the part of the lung that you're operating on. Some of the problems with bronchial blocker or disadvantages: has a small channel for suctioning. It's difficult to suction through. If you want to convert from 1 to 2 and then back to 1 lung and you're doing it multiple times, sometimes that's a little bit more difficult, and it's not uncommon for that bronchial blocker to get dislodged, move, and that is probably one of the IT-related bronchial blocker complications, which is dislodgement, more frequent than a double lumen tube. And a rare but risk is if you're passing that bronchial blocker out far, it may go out and actually perforate a bronchus. Let's move on now to one lung ventilation parameters. How do you set your ventilator after you establish one lung ventilation? Well, with lower tidal volume, somewhere between 5 to 6 mils per kilogram. Keep your plateau airway pressures and peak airway pressures low, usually adding a little bit of PEEP, about 5. And in patients with COPD who already have trapped air and big residual volume, often not adding PEEP to those patients. But keeping the tidal volume down and the peak airway and the plateau pressures down is our goal during one lung ventilation and setting our ventilator. What about one lung ventilation and hypoxia management? That is, you put a double lumen tube down or establish one lung ventilation with a bronchial blocker, and you have severe or precipitous desaturation. You're at 99% and suddenly it goes down into the mid-70s. In that case, that's life-threatening hypoxia down there in the mid-70s, and you should resume two-lung ventilation and check your positioning, which is often the problem of that double lumen tube or bronchial blocker. So precipitous desaturation, resume two-lung ventilation, figure out what the problem is. More often it's a gradual desaturation where your saturation starts in the 90s and slowly it's going down, and next thing you know it's in the mid to high 80s, and what do you do? Well, one, make sure you're delivering an FiO2 100%. Check the position, if you haven't done it already, or do it again, of your double lumen tube or bronchial blocker with a fiber optic bronchoscope. You got to have adequate flow and pressures. Those can affect oxygenation by changing zones of the lung, actually. So you got to have a decent cardiac output and blood pressure. If you're hypotensive and you're on a high MAC volatile concentration, you may want to turn that down. Recruit the ventilated lung. That is, add a sustained positive pressure breath, holding it, popping open that ventilated lung, which may be just atelectatic. And then apply PEEP of 5 centimeters of water to the dependent ventilated lung, except in patients with emphysema. And then the next step, if all of those are not getting you back up into the 90s where you want to be, there's commercially available as well as apparatus that you can make where you can supply CPAP to that lung that's being operated on, the non-ventilated lung, and that recruits some of it, opens some of it up, and reduces the overall shunt. If the surgeon allows it, another thing you can do is intermittently reinflate the non-ventilated lung. Of course, it gets in their way and they have to stop surgery usually during that time. There are some partial ventilation techniques of the non-ventilated lung, like oxygen insufflation, high-frequency ventilation, or even putting that bronchial blocker out, as we talked previously about a lobar rather than the whole lung collapse. Lastly, mechanical restriction of blood flow to the non-ventilated lung is the most effective way to decrease shunt. So if you're going to remove the left lung, for example, you can clamp the left pulmonary artery that forces all the blood to go to the ventilated lung, and your shunt goes away, and your oxygenation usually improves dramatically at that point. The next keyword is lasers and airway fire. Airway fire prevention was an IT keyword in 2019. To decrease the risk of laser-generated airway fire, for example, if you're working on a bronchus and frying a tumor with the laser in the bronchus or a trachea, reduce flammability of the endotracheal tube. Flexible stainless steel endotracheal tubes are available, some with dual cuffs. For example, at the top right, there's a dual cuffed stainless steel one. If the laser hits one of those cuffs and blows it, you still have one other cuff. Some will even put saline and methylene blue in one of the cuffs or both of the cuffs, such that if the laser hits it, that methylene blue spreads in the airway and you know immediately that the cuff has been ruptured. Moisten exposed surfaces near the laser, and any saline, any gauze that you use, make sure it's not dry, soak it in saline, which will reduce the risk of a fire. PVC tubes are flammable, but less than red rubber or silicone endotracheal tubes, and flexible steel are the least flammable. You should reduce the available FiO2. Less than 30% is usually recommended. Avoid nitrous oxide because it can support combustion. And so communicating with your surgeon, knowing when they're going to fire the laser or electrocautery in an airway, and trying to keep the FiO2 low. Sometimes removing the potentially flammable material from the airway and doing laser during that time, such as an apneic technique, or removing the tube, ventilating through a rigid bronchoscope, putting a small tube down, ventilating, removing the tube, and then doing laser in between, placing the tube back and ventilating. Lots of different techniques to try to get that endotracheal tube out of the airway during the period of lasering. If an airway fire occurs, a tube is in place during a laser procedure, for example, smoke is pouring out of the airway, you remove the tube. That's the very first step. Stop ventilation, flood the surgical field with saline, ventilate by mask, reintubate bronch to look for damage, monitor in the ICU, sometimes steroids, humidified oxygen, and oftentimes ventilatory support is required. But removing the endotracheal tube is considered the first recommended step by the American Society of Anesthesia Practice Advisory, which is shown here. The ASA Advisory for Operating Room Fires algorithm first talks about at the top fire prevention, getting the ignition sources away from an oxygen-enriched environment. The drapes, the skin prep sometimes can be flammable, but usually that's talking about for example, surgeries up around the face and the neck, and MAC-related cases where nasocannula oxygen is going and a plastic surgeon operates up around the face where oxygen becomes trapped from the nasal cannula and a fire occurs. We are talking more about down in the airway, the classic airway fire. So we follow that algorithm down, and we should know when the ignition source is going to be fired, so the surgeon should let us know. We should reduce the oxygen concentration to the minimum required to avoid hypoxia, often less than 30%. Stop the use of nitrous if you're using nitrous, and if the fire occurs, the first step down at the red star is remove the tracheal tube. The next key word is closing capacity, and we're going to talk about that before obesity and aging, because closing capacity has changed in aging. Closing capacity is the lung volume at which the small airways begin to collapse. And if you look at the graphic on the far right, which has y-axis being lung volume and x-axis being age, you can see that the closing capacity is increasing with age, and at age 44, in the supine position, they actually cross. So the end of a tidal volume breath, you're at the closing capacity, and then at 66 years, even in the upright position, you can see that functional residual capacity and closing capacity are crossed. So closing capacity increases the lung volume at which the small airways begin to collapse as you age, and even in the standing position, upright position at 66 years old, they're crossing FRC and CC. Things that increase the closing capacity other than age: obstructive pulmonary disease, smoking, upper abdominal surgery. And let's look at aging as the next key word and the changes in the respiratory system. First, looking at the graphic on the far right, on y-axis is volume of lung in liters, on x-axis is age. We'll first look at residual volume. Residual volume is the gas that's trapped in your lung at the end of a forced exhalation. That is, if you ask someone to blow out as much air as you can, force it all out, and they do so, the gas that's in the lung that's trapped, which cannot be measured by spirometry, is residual volume. And you can see that that residual volume is increasing with age. Look at the FRC. FRC is made up of expiratory reserve volume and residual volume. It increases. So aging increases FRC. And we already mentioned that the closing capacity was increasing as we age. So if those small airways are starting to close off at high tidal volumes, you can see how VQ mismatching can occur in an elderly patient. So things that are increased: residual volume, that's trapped air in the lung; FRC, closing capacity; and the lung compliance itself. The lung of the elderly starts to act like a rubber band that doesn't want to snap back. It's like an emphysematous lung. It's a boggy lung, and instead of inflating and going back then to a small volume, it is very compliant and does not want to snap back to a small volume, so there's a high FRC. Also, as you age, you lose alveolar surface area. Your PaO2 tends to be lower. In fact, there's equations that help us predict, based upon age, what the PaO2 should be. And someone who's about 90 years old, a normal PaO2 could be down in the 60 to low 70 range. And laryngeal reflexes are decreased in patients as they age. As you do DL on an elderly patient, a very old patient, sometimes you'll actually see food around the larynx, and you go, how can they stand that? And then you realize, well, their laryngeal reflexes just aren't the same as they were when they were younger. Aging and respiratory changes, part 2, what happens in the lung parenchyma itself. There is VQ mismatching, and that is age-related, and so PaO2 drops as you age. We said that the lungs act like they're emphysematous, and they have a higher trapped air in them, residual volume, and a higher functional residual capacity. They have a lower alveolar gas exchange surface area. So that's the lung. Well, what about control of ventilation? Response to carbon dioxide and hypoxemia. Both of those are impaired as you age. That is, as CO2 goes up, you should breathe faster. As oxygen goes down, you should breathe faster. And this is not as good as you age. Respiratory bellows, that is the strength of the chest wall, the compliance of the chest wall, muscle strength, all are impaired in the elderly. The conducting airways, usually there's not much changes there, and we already mentioned that airway reflexes are decreased. The next key word is morbid obesity and respiratory changes. In the obese patient, the lung itself is usually not the problem unless they have a concomitant lung disease. It is the chest wall. All of that fat on the chest wall, adipose tissue, decreases the chest wall compliance. If you do pulmonary function tests in someone with a morbid obesity, they tend to have a restrictive pattern. That is low lung volumes, expiratory reserve volume, FRC, total lung capacity. Think of small lung volumes and a restrictive ventilation defect. We know that in restriction that the ratio of FEV1 to FVC is normal, even though both are reduced. So they have a lower flow FEV1 rate, a lower FVC, but when you put them in a ratio, it's greater than 80%. And we say, aha, that's a restrictive pattern. They use more oxygen, this morbidly obese patient, because there's more tissue. They produce more carbon dioxide from all those adipose cells, and their minute ventilation needs to be higher to keep their CO2 normal. They often have chronic hypoxemia, and some even have hypoxemia and hypercarbia. Pulmonary hypertension tends to be associated with chronic hypoxia and hypercarbia. And when you put a morbidly obese patient to sleep, rapid desaturation is expected. Why? For several reasons. One, they have a low FRC, so when they stop breathing with induction meds like propofol, the FRC is the volume of gas that's in your lung at the end of an unforced exhalation or normal tidal volume, and that's what you're using gas oxygen from during the period of apnea. If it's low, you have less to use from, and they're going to desaturate faster. So not only that low FRC, but also their increased oxygen consumption contribute to the rapid desaturation in obese patients when they become apneic. Now, looking graphically at morbid obesity and respiratory changes, on the y-axis is total lung capacity, and on the x-axis is comparing a non-obese on the far left with an obese patient on the far right. And so let's look at the obese patient. Look at their tidal volume breathing is actually below the closing capacity. So there's a lot of airways that are closed off, small airways, and this is a big VQ mismatch problem. Their closing capacity itself is the same as a non-obese patient, but look at their tidal volume. Their FRC is reduced. Their breathing, as they go from a sitting or standing position into a supine position, their tidal volume becomes even lower in their lung volumes, way below closing capacity. And then if you put them in Trendelenburg, also their tidal volume breaths are way, way, way below the closing capacity. And you can have a respiratory arrest in a morbidly obese patient simply by putting them supine or putting them supine and in Trendelenburg position because of this. So at normal tidal volume ventilation, much of breathing in an obese patient is occurring at volumes below the closing capacity and closing volume, and therefore VQ mismatch and hypoxia occur. The next keyword is obesity hypoventilation syndrome, comparing it with obstructive sleep apnea. And let's look at obstructive sleep apnea first. OSA tends to occur in the classic male patient who is often obese, but not necessarily, who snores at night and chokes or gasps during their sleep, and their partner says, yeah, they snore really loudly when you talk in the preoperative area and ask if they snore. So this male snores at night, gasps in the middle of the night, awakens frequently, and if you sent them off for a polysomnography exam, they would have an AHI index, apnea-hypopnea index, which we're going to talk about next, or obstructive breathing events during each hour of sleep, more than 5. So very frequently they're awakening, startling, gasping, and then go back to sleep. That's the classic obstructive sleep apnea, where obesity hypoventilation has a pretty much equal gender distribution. They're often obese. What's going on at night is they don't have this gasping. Actually, their CO2 builds up and their oxygen goes down in the night, and it's like their brainstem doesn't care, and they don't hyperventilate, and they don't awaken. And so this chronic hypoxemia and hypercarbia can result in pulmonary hypertension, which is more common in the OHS patient than in the OSA patient. So if you're monitoring them at a sleep polysomnography nocturnal monitoring, you will see an increased PaCO2 during sleep, greater than 10 millimeters of mercury from awake supine values. Their oxygen desaturation occurs during sleep, and they're not having periods of that gasping, apnea or hypopnea that is classically with OSA. So let's look at OSA prediction, and polysomnography is our next key word. The picture at the top right shows a patient with posterior pharyngeal tissues obstructing airflow through either the nasopharynx or through the oral pharynx back into the trachea. And this is the person who in the middle of the night is going to wake up gasping and then go back to sleep and do that multiple times throughout the night unless they're using a CPAP device. So obstructive sleep apnea is associated with high blood pressure, both of the systemic and pulmonary system, coronary disease, heart failure, dysrhythmias, stroke. So diagnosing it and managing it is important. And in the preoperative clinic, one way to predict it is to ask questions related to the Stop Bang Score questionnaire. And STOPBANG stands for the S first is snoring, asking the patient, do you snore loudly at night? Usually you don't ask the patient, you ask someone, their significant other, and then you ask, are you tired during the day? Fatigued, sleepy during the daytime, often easily fall off to sleep. The O, observed apnea. Has someone seen you stop breathing during your sleep? Is their blood pressure up, or are you being currently treated for high blood pressure? BMI, often greater than 35. Body mass index. Age, often greater than 50. Neck circumference, often a big neck. And gender, more commonly a male. Those in the Stop Bang questionnaire would support the positive response to these would support the presence of OSA or likely presence of OSA. And you would send this person off for polysomnography testing or sleep testing. And at the bottom right shows some things that are monitored during polysomnography. The first squiggly line represents the EEG. The next line is electromyogram of muscle activity. The next one, the third one down, is both flow through the nares or the oral pharynx, and thoracic movement and abdominal movement, and then oxygen saturation followed by the electrocardiogram. All these things are monitored. So you can imagine being hooked up to all these things. I've actually personally undergone a polysomnography exam. And I don't know how you can expect anyone to sleep. I sure had problems sleeping with all those things hooked up to you. But let's say you go off to sleep, and then in the middle of the night, you have a period where you have some apnea. When the apnea occurs, all of a sudden your brain senses it and arousal occurs on the EEG. Oftentimes you begin to desaturate from that period of an apnea and obstruction. You start thoracic movement because you're obstructed and the muscles start moving, trying to get air in against the obstruction. You may even become bradycardic if the desaturation occurs deeply. So you have this arousal, awakening. You awaken enough to stop the obstruction and then go back to a normal pattern. And this happens over and over. If the sum of the apneas or pauses in breathing plus the number of hypopneas, which is periods of shallow breathing, when they're averaged out per hour and they're greater than 5 per hour, it's considered between 5 and 15 mild, 15 to 30 moderate, and greater than 30 severe. So if someone had, let's say, over a period of 8 hours of sleep, had 80 apnea, hypopnea spells, that would be 80 divided by 8 hours, or 10 averaged per hour, and this would be in the mild range. So polysomnography is a way to diagnose obstructive sleep apnea or other causes of sleep issues. This ends videocast number 4 of a total of 5 on the topic of high yield keywords, respiratory and thoracic topics. Have a wonderful day.